Hello everyone, I'm Tanmay. My topic for today's presentation is rectus femoris tendon transfer. Cerebral palsy is a group of non-progressive disorders of movement and posture, and muscle spasticity, contractures, muscle bone length abnormalities, and altered biomechanics cause various gait problems in these children. However, amongst the common grade gait problems at the knee joint are jump knee, crouch knee, stiff knee, and recurvatum knee. And stiff knee is caused by a rectus femoris overactivity, and that is my topic of presentation. As you see in this picture, when the child walks and he has stiff knee, because of the overactivity of the rectus, the hamstrings cannot overcome its pull and they cannot flex the knee, and that is why the child cannot clear the toe off the ground or the foot off the ground and needs to drag it to walk, or he uses his trunk compensation and circumducts his leg to walk. The muscle in question, which is rectus femoris, is a part of the quadriceps group of muscle. The rectus femoris is amongst them the biarticular muscle, which works as an hip flexor as well as a knee extensor. It is innervated by the femoral nerve, and it originates from the anterior inferior iliac spine and the innominate portion of the pelvis, while it is inserted with the tendons of all the remaining three triceps femoris muscle and joints at the superior pole of the patella. Rectus femoris basically acts during the gait from transition from the stance phase to the swing phase, basically during the initial one third of the initial swing phase. It has been argued whether it is active during the mid swing phase. However, whenever there is transition again from the end of the swing phase to the stance phase, rectus femoris acts. In kids with cerebral palsy, the rectus femoris exhibits normal length during the first 6 years of the child. That is when there is no growth spurt in these children. But when the child loads his leg, that is in weight bearing, that is standing or walking, the rectus femoris shows exaggerated response. However, kids from 6 to 12 years of age show growth spurt, and that causes lengthening of the femur, but the muscle spindle fibers of the rectus femoris muscle do not lengthen according to the bone, and that causes disproportion, and that also leads to myostatic shortening, that is the muscle fibers do not lengthen and remain shortened, and that may lead to permanent shortening or contractures. Typically, these children face problems during ambulation due to overactivity of the rectus femoris muscle, while the gait analysis of these children show delayed or reduced knee flexion during the swing phase. There is decreased hip flexion while transition from stance to swing and also from swing to initial stance. There is decreased ankle dorsiflexion during the swing, leading to toe drag, and these are the contributing factors for stiff knee gait. As the child cannot clear off his toe, he succumbs to falling while playing with the piers or wearing of the shoe at the toes. How is the stiff knee managed? Neurologists and physicians give medications to reduce the spastic muscle or the action of the spastic muscle. Orthopedics suggest surgeries, while physical therapists like us go for functional therapies, strengthening of the muscles, etc. Children who are less than 6 years of age are preferred for non-operative management as the first line of care. So functional grade training, using of braces, medications are advantageous at this age, while children who are above 6 years of age have been mostly recommended for surgical treatment. as non-operative interventions have not shown that much significant benefits. The pre-surgery and post-surgery rehab is considered very important prior to the surgeries, as well as one should remember that rectus femoris transfer is not an individual surgery which takes place. It is always amongst multi-level surgeries. So the other accompanying surgeries may be the tendo-Achilles lengthening or the patellar collection or the adductor lengthening, etc. The indications which many orthopedicians have suggested for rectus femoris transfers are a combination of the following ones. Like if parents complain that the child tracks his toes, or on physical examination the Duncan-Ellis test comes as positive, either it's specifically the slow rectus test, positive slow rectus test, which indicates it is the shortening of the rectus femoris muscle, abnormal EMG activity, or certain parents want to prevent secondary complications and they go in for surgeries, while gait analysis indicates reduced peak knee flexion in the swing phase. Initial one-third of the initial swing phase is reduced. Gait velocity below 70% of the normal gait velocity for that age, while some orthopedicians also see if the total range of knee motion is below 50 degrees, they suggest surgeries. Pre-surgery therapy, like these children are already undergoing therapy for their multiple problems. So before the surgery, specifically their GM-FCS levels are tested. Their gait analysis and kinematic characteristics must be recorded. The therapy interventions which are going on must focus more on the strengthening of the muscles of the trunk, the lower extremity, as after the surgery the muscles show a decline in the overall power till the healing and recovery takes place. As these children undergo multi-level surgeries, strengthening exercise to increase the strength of the core, like bridging, prone planks, side planks with functional outcomes, can be beneficial. Abdominal strengthening, the quadriceps group of muscle is also strengthened, because theoretically in this surgery it is thought that the triceps femoris group loses most of its power post surgery. Hence, to recover the power, the strengthening must be done pre-surgery. While the hamstring group of muscles, dorsiflexors and toe extensors also should undergo intense strengthening, because for knee flexion and clearance of toe, these muscles act. Gait training must concentrate on achieving ambulation or improving of endurance, as that would be beneficial for the child post surgery. A week before the surgery, it is suggested that the GMFCS level, the gait analysis results, and an ambulation video of the child must be recorded. We must explain the parents why the surgery is needed, what will exactly take place during the surgery, the process, how it will affect the child, how after the surgery what we are going to expect, the risks, the complications, the medications required. Post surgery, the physical therapy intensity, frequency and duration, and how the exercise are going to progress. We can also show videos of other children pre and post surgery, so that parents are satisfied and they do not panic because of this surgery. We can give written instructions and pamphlets. Give time to the parents, because they should comprehend and discuss this, and so that they can get back to you with the doubts. While the child also needs to be explained, like what the surgery is going to do to him, and after the surgery for how much period he would be on the bed, and when he would start exercising again, and how much exercise or the level of contribution is required from him. The rectus femoris transfer or resection, a vertical incision is usually given on the anterior surface of the quadriceps muscles. Then navigating through the fascia vascular supplies, the muscles are separated and the tendon of the knee extensor is identified, while the rectus femoris tendon is lifted up and resected at a level higher than the attachment to the patella. In this resection, the remaining end is sutured to the muscles underneath if it is a resection, or if it is a transfer, it is transferred medially to the semitendinous muscle. While suturing, the line of pull of the muscle must be straight, the muscle belly must be stretched a little, and the suture should be that it should leave minimum scar. Many research studies have shown that the tendon transfer is more beneficial to reduce the overactivity of the muscle, and it allows hamstring to contract and cause knee flexion. However, transfers to either the medial or lateral side have not shown any difference in kinematics during the stance phase. However, during the swing phase, the medial transfers have shown better outcomes. Medially, the muscle can be attached to any of the hamstring muscles, but as semitendinous is another biarticular muscle, it is preferred one. The proximal release of rectus femoris has not been supported by the research, so it is not done nowadays. Evidence also shows that rectus femoris after the transfer does not act as a knee flexor, it continues to fire as a knee extensor. However, its overactivity reduces and thus normal knee actions are possible. Few studies have supported resection of the tendon over transfer. However, the advantage of resection is the ease of the technique being less invasive and no residual scar tissue. This is where the line shows where the tendon is resected and the remaining tendon is sutured. Immediately post-op, there is fluid, electrolyte and blood loss management which takes place. A padded plaster is applied to the joint to immobilize it and to reduce the swelling. The joint is immobilized for 1-2 weeks, but in between we can give passive range of exercises, maybe start with few static exercises. Upper limb exercises and breathing exercises can be done. Cryotherapy can be done for reducing the swelling, and pain medications are a must for the children. Weight bearing exercises and standing exercises are started probably after 2 weeks, and gait training can be started within 2 to 6 weeks. These children can be rehabilitated in an inpatient unit as well as an outpatient unit, and as their level of function drops below the pre-op level, initially we help them to come up to the pre-op level and then we concentrate on achieving further function. Studies have shown that the minimum intensity of physical therapy rehab must be an hour daily for at least twice a week sessions, and this may continue to 3 to 6 weeks or a maximum of 3 to 6 months. And more therapy sessions can be achieved in inpatient and outpatient depending upon how the parents want it. Re-evaluations take place every month for the first 3 months and then every 3 months till the period of 1 year. Orthopedic re-evaluations by the surgeons also take place at 3 months and then every 6 months for a year and then once every year. Research have recorded re-evaluation improvements till 10 years post-op. Physical therapy interventions concentrate on muscle strengthening at the hip, at the knee, at the ankle. Functional activities like sit to stands, transition, transfers can be worked on regularly. Supported weight bearing, standing, walking is practiced. Ambulation with assistive devices. Hydrotherapy has been shown to improve the overall strength of the lower limb, while sensory integration has, along with the motor exercises, have shown benefits, especially children undergoing multi-level surgeries. Gait training with visual and auditory feedback have also shown promises, while treadmill walking has shown that the repetition of the continuous movements helps to improve the gait pattern. Concluding it, the rectus femoris tendon transfer is a common surgery amongst the multi-level surgeries which take place in children with cerebral palsy. However, physical therapy interventions specific to the rectus femoris transfer have not been explored till now. Few orthopedic outcome studies have shown improved peak knee flexion during the swing phase, reduced toe drag, and improved control on speed during the swing phase till 7 years post op. One study showed it up to 10 years, but the sample was very less, that is, only 10 uh, children were there as the participants. While one study has showed that pre-operative power in the hip musculature, knee musculature, and knee flexion velocity at toe off predicts 80% of the post-op outcomes, while adding hip flexion and internal rotation strength increases the prediction accuracy to 88%. These are the references, and thank you so much for watching my presentation.